how can startups, tech startups, embark onto this trend of more and more value-based reimbursement. Let me start off by introducing the panelists. First, from Nina Capital, we have Marta. Marta is the managing partner. And a few words about Nina Capital. It's a venture capital firm who invests mainly in healthcare transformation through information technology. They invest in companies that facilitate the transition to value-based healthcare, either by tech-enabling providers or by risk-bearing alternative care providers. Nina Capital operates internationally. Investments are being made in the United States, Canada, Europe, and Israel. Thank you for being here. Then we go to Sascha. Sascha is partner at Vorwerk Ventures, also venture capital in Germany this time. They specialize in early-stage investments across various sectors, but Sascha is involved in the healthcare sector, and there the focus is on digital health and value-based care. And then from the provider side, we have Robert, who works as an insurer contractor for healthcare clinics in the Netherlands, and he has an experience in multi-year contracting with healthcare insurers and also value-driven contracting, where he will give some examples from. Welcome. And last, my name is Bart Bijlsma. I'm medical director at a chain of healthcare clinics in medical specialty sector. I have a background, also worked as a physician, but later moved to more management. Worked in hospitals that are improving using value-based healthcare tools, but also worked as a healthcare insurer in creating new value-based payment systems to improve the quality of care. But before we start in the discussion, just give a very short overview of what is value-based reimbursement. Value-based reimbursement is opposed to volume-based reimbursement, where you pay fee for service. To give you an example, for diabetes care, for example, volume-based fee-for-service reimbursement would be that you, as a diabetes patient, would go to see your clinician, and then they would bill you for going to the physician, for the lab test they did, maybe the nurse consultations you had. Why is that wrong? Because in that way of payment, of course, there's an intention to give good care, but there will also be an intention for upsell, maybe order some extra blood tests because it will, in the end, make more profit for the hospital. So opposed to that, there are some systems. It's more like a spectrum of different contracting practices, where we have three main archetypes. We have the pay for performance, the bundled payment, and we have the population-based payment. In pay for performance, the easiest of the three, it's adding an extra payment based on the outcome that you negotiate. For example, with the diabetes patient, paying more if the blood glucose level is under control. Then you have a bundled payment. That would mean that you pay for a disease, for example, diabetes patients, within a certain time period, and there you would include all the care that's being delivered for those diabetes patients. And last, we have the population-based model, which is even larger. There you say, okay, as a provider, you take care of all the care related to, for example, diabetes patients in Amsterdam. So you have a geographical area, and you have even a broader set. And in that system, there's also an incentive to work on prevention, because preventing a diabetes patient from going into higher stages diabetes will also prevent cost. And you as a provider will be bearing much more risks. Just to set the stage there, let's get to some examples. I'd like to start there with you, Marta. Could you give some examples of how you're working on value-based reimbursement?
Yes, absolutely. So, well, as you said, value-based care is all in the end about risk management. In the healthcare version of it, not in the way your car insurer intends it. They're not here to manage non-controllable risk. Companies that are engaged in value-based care are trying to control risk that can be controlled, the medical risk. And then they get paid for it. Now, startups in this space have tremendous lots of opportunities, because this is a space in transformation. In the purest fee-for-service scenario, providers don't take any risk at all. Now they have to transition to take some, or in some cases, or in capitation, all of it. And making this transition is excruciatingly difficult. There are concerns about, well, risk attribution. Okay, I'm taking on risk, but am I responsible for it? Or when my patient goes from a primary care to the specialty care, moves from one provider to the next one, who is responsible for that risk? Who should pay? Who should take the responsibility for that risk is not trivial. So there are opportunities for startups to understand how to help providers and solve the attribution issue. Attribution means you're measuring something. If you're responsible for something, you'd like to know what are the measures that are able to tell the provider whether they have delivered on their job or they are taking on risk they were not able to control. Measuring is extremely difficult. So startups have the opportunity to understand how to make those measures clear, easy to gather, and standardized in such a way that they can be shared between different providers and the payers that ultimately pay for the attribution of that risk. You have opportunities about care coordination. Very rarely a patient has one single interaction with a provider. They move across different providers, and so startups have the possibility to help providers who take on risk coordinate better the care of the patients to manage the risk that the patient may fall through the cracks. One way to take on risk is to put some of it back on the patient. What we call patient engagement is actually just a way to offload some of the risk-bearing responsibilities by asking the patients to be more engaged in their own healthcare. So opportunities are there for startups to foster patient engagement, and that helps providers eventually manage their controllable risk. So you just have to think about the challenge of making this transition from measuring to having the data infrastructure that supports that measuring, to understanding how to control that medical risk in various interventions through a patient pathway that involves care coordination and the patient engagement itself. All of these things, companies need support, healthcare providers need support, and startups have an opportunity to bring in technology to develop it. Now, what I'm describing right now is what I call the value-based enablers. Startups that actually see the challenge for providers and present technology solutions to solve them. These are companies like Adaptation Health, for example. They come in, they understand the provider's risk, and they offer technology solutions to manage it. But themselves, many startups actually have become extremely successful by becoming themselves tech-enabled providers who are better at managing risk. Oak Health in this strategy is itself a value-based care tech-enabled provider that reached last evaluation of $8 billion, not bad for the startups. And they did so by understanding that the technology that they had worked so well that instead of selling it to someone else on a SaaS business model on the cheap, they could leverage it themselves to become the best providers that they could be and capture a significant portion of the money that was made available by payers that were fostering the transition to value-based care. And then you have the ones in the middle, the hybrids that have developed some technologies themselves providing care, but see the opportunity to also sell it for a profit to other providers that instead are struggling to do so. If you look in our portfolio, you will find flavors of all. Actually, that's not correct. We have invested in companies that are themselves enabler of the value-based care transition. That would be Connective Health in our portfolio. And then we have invested in companies that themselves are providers on care and have signed on at-risk contracts with payers. That would be the example of Sober Psychic, and are themselves essentially engaged in a provision of cares in a value-based care contract. So this is my 2 cents, some concrete examples, both on the portfolio and outside. And well.
Thank you for providing the examples of both the enablers and the providers. Very insightful. So let's move to you, Sascha. Maybe you have some interesting examples to share as well.
I want to show something or share something from Germany, because ultimately what Marta just described, I mean, this is amazing everything is possible with value-based care. Looking at one of the largest health markets, how we approach basically value-based care, it's kind of sad, because ultimately everything that you just described is healthcare, value-based care enablers, is not in place yet. And I think there are a couple of companies that do a tremendous job basically helping to enable interoperability, for example, so that you can measure the outcomes finally. There's some of them focusing more on the care delivery. But ultimately, I think what needs to be mentioned a little bit is you need a systemic change as well. You know, you need to work and operate in a system where value-based care is then also appreciated by the policymakers. And I think this is something where we in Germany struggle still a little bit, is really getting there and setting the incentives right for the statutory insurance, for the insurances themselves to really offer such solutions. We have companies in Germany that go in the direction of value-based care but still start off with a fee-for-service model. We invested, for example, in AV Medical. It's a GP practice chain, kind of comparable to the One Medical in the US. And you know, you need to work in the system first, because otherwise it's super tough to get any money. And then once you have a patient base and access to that, you can think about really value-based care in a way of working with insurances, develop selective contracts with them in order to create opportunities that are better than for the patient, but also then better for the system. So I think here we can learn a lot from other markets in Europe, especially also when looking over to the US, where like the health system has been developed only over the past few years, and value-based care is very much in the focus of the ambitions.
Thank you. Good that you also mentioned the differences between the countries. Would be good to also ask your opinion then, if you say maybe Germany is less far away, far ahead, would you suggest then also that you should start in the US, or what's your thinking there?
If I was a startup but focusing really on the outcomes, I think the US market might be the better choice if you have some angle to this market that makes sense. I wouldn't recommend to like a German-based founder that is born and raised there and doesn't want to move away just to go there just because he wants to build a startup there. You can also build it in Germany, but you have to take into consideration that it might take quite some time in order to establish that. And I think that's maybe an issue in Europe, is when you expand into new markets, it gets like you have to undergo the same thing over and over again because the systems are not the same, right? So you have to adjust and adapt, which costs a lot of money and time. So I think if you opt for Europe or Germany, you just need like a long breath and hopefully a lot of capital in your back. Yeah.
Thank you. Well, let's move to the Netherlands, Robert. What would you like to share?
Maybe you can consider to go to the Netherlands. It's a small market, but as a member of the Finance and Contracting Committee of Independent Clinics Netherlands, we've got 190 clinics, and we do 17.5% of all the elective medical care in the Netherlands. So it's really relevant party in the Netherlands. They're all organized like the value-based healthcare principles. So we are a little bit ahead of Germany, I think. What we've done, of what a few clinics have done, is made a bundle payment arrangement with a large insurance company. And from that perspective, I think there are three takeaways. What is the benefits for a clinic is you've got a whole different conversation, negotiation with your insurance company. You're not only talking about the price, you're not only talking about the volume, but where you really are talking about is the outcomes of the clinical care you're given. And that's really different. So you give the opportunity, you get the opportunity to get in another conversation with your insurance company. And that's from, I think, an investor perspective, really good, but that kind of contracts are multi-year contracts, so there is some base for the coming years. For the provider perspective, it's really helpful. We are organized like value-based healthcare, but if you're not contracting like value-based healthcare, you still have some incentives for the fee-for-service. Right? So if you do a little bit more, you get more paid. If you got a bundle payment, those incentives are really different. You can really facilitate or stimulate innovation, where innovation not directly lead to less contracts or less payments. So that's for the provider. It's really helpful to organize your continuous learning cycles. But most of all, I think it's the best for patients and society. We heard it a lot this day about shared decision making. But now, if you got a bundle payment, and a bundle payment is the clinic is responsible for 365 days of care, all the cares, the surgical care, the non-surgical care, the complications, everything it's needed. So you are, as a provider, responsible for given all the care. And in the treatment room with the doctor and the patients, you can talk about what is the best treatment for you. So you make the decision on what are the best outcomes for you, and not if the treatment is financially covered by your insurance company, or it's too expensive to pay it out of pocket money. So what bundle payments helps us is have the real shared decision making in the treatment room. So that's, yeah.
I'd like to build on that because you say something very important, that it is true in the United States, and I find sometimes people don't appreciate. They think that they're speaking with a provider, and they think that the provider itself can be attached to a particular implementation of value-based care. In reality, in the United States, well, you have 100 million people that are in some form of value-based care coverage, but a single provider may be in a ton of different contracts, some fee-for-service, some bundle payment, some they're sharing the risk, some they're sharing the savings. And navigating that complexity, I find, is extremely difficult, especially for companies that are in Europe, thinking that they can go to the United States and save the world and help with the implementation of value-based care. Within a very large provider organization that has both primary care and specialty care, you may find primary care has moved on very well to a value-based care implementation, especially there's nothing. Go to the orthopedics department, and they do bundle payment extremely well. So it's very complicated for entrepreneurs to understand that what looks like a very homogeneous and very exciting large healthcare market opportunity in the United States is actually still extremely fragmented. It's in a lot of movement, and in the specialty care area, it remains a really wide space of innovation with tremendous opportunities to be made.
Yeah.
And a question then to you, because I think you're picturing that we're in a transition phase, so everyone has to work with mixed models, bundled payments, capitation. Where do you think it will go? Will we leave fee-for-service fully, or what extent will we get to with value-based reimbursement?
Well, we've been on this transition for 20-some years, maybe even longer, and we have made significant progress in the United States in primary care. But again, the specialty care journey is still essentially at its beginning. So I don't expect that we'll be able to leave and see that I have seen the end of that transition. I think this is decades in the making, which for me is very exciting. First of all, it's an imperative. The situation as it goes is unsustainable, so it's an imperative that we walk this transition, but it is also one that it's extremely difficult for very large businesses that have hundreds of thousands of lives at stake to make. And so I'm not here advocating any urgency. We do it right. It'll take decades but it will continue because there is no other solution. And the great thing is that for startups that are in this conference, making this transition cannot happen without technology. At the end of the day, when you're trying to understand how to manage risk, at the minimum, you need a very robust technology infrastructure to measure and understand what to do with those measures. And that's where technology comes in, information technology.
Yeah. And in our pre-discussion, you also mentioned that you see some transitions from a startup that starts taking on the first kind of role, then transitions towards another one. Could you explain a little about that?
Yes, absolutely. So again, opportunities to take on risks were first understood by entrepreneurs that are in the healthcare business themselves taking care of patients. And so as they adapted to the possibility to take on risk, some of them actually ended up developing the technology that they felt was absent in the market in order to assume the management of that risk. And some of them realized that the technology that they have developed was as valuable as a business or even more than the business of healthcare they were in the beginning. So the initial pioneers of this space were actually those that they were in the business of care services that developed internally the technology capabilities to support the ability to deliver value-based care, and then realized that this technology was extremely valuable to enable others to become such. So in ways, some hybrids even were first than the technology enablers out there. I think this is one of the businesses in which I've seen the insiders, both from the informatics to healthcare and the pure healthcare businesses thrive the best, because it's really down to fundamentals. If you don't understand the subtleties and the complexities, you're never going to get out of this mess in time to make the seed round happen.
Thank you.
I would agree to this. I mean, ultimately, I think it always depends in which stage the user is that you're actually, or the customer that you're selling to. And I think if you're really good in building that technology and creating that edge, actually going into a different kind of reimbursement, often the providers are just not there yet. And it takes a lot of time, long sales cycles, a lot of unsuccessful meetings that I guess a lot of people in the audience know. And I think sometimes then the best move is just to say, look, if you guys are not ready, then I'm taking on the risk myself and basically starting to compete against those incumbents, right? And we see that in a couple of models where you build initially, for example, some software for clinical trials, and then you realize maybe I need to become a CRO myself in order to become more efficient. And I think when it comes to value-based reimbursement or value-based care provision, this is maybe a natural way to go. Until then, I'm a firm believer that then the other incumbent players, they will follow because they realize, oh, there's something happening that makes sense. And then this then actually stirs innovation and then helps also then the software players again to sell the software to them because they become ready. So I guess it's always like a pendulum that goes from left to right, and you need to find the right spot for your model, and don't be only stick and very firm on your one that you chose at the beginning. Maybe you need to be a little bit more flexible here.
I think it took us 5 years to come to a bundle payment, and it was a quite easy bundle payment only for hand and wrist. But still it took us 5 years. And there are numbers of reasons to not go further with the bundle payment, but there is one reason to go further if you believe in it. It's the solution, and you have the medical leadership, then you do it. And you're a front runner. And I think in the Netherlands, all the independent clinics are front runners in their way. And they believe we have to innovate on technology, we have to innovate on process, but we also have to innovate on how we contract, how we finance, and how we reimburse. If we forget that, I don't think the adaptation of technology will start.
In the meantime, the sad thing is that we're adding a lot of middleware, intermediaries that perhaps we shouldn't need in an ideal world. Some of the, we're having a lot of fun in the space. Some of the weirdest thing we're seeing is maybe the equivalent of the transmogrifier in Calvin and Hobbes. I don't know if you've ever seen the thing, put something in a box and something comes out. So there are even startups that have built entire businesses just sandwiched in the middle between a fee-for-service provider and a value-based care payer. They're taking on the risk, and their business is just to adapt it so that the payers can work in a value-based care environment. These are some of the largest and most interesting businesses I've seen investing in the space, but nobody talks about them because honestly they're not sexy at all. But they are making significant volumes of revenues just to help this implementation and this translation of the old with the new. I hope in one day they will not be necessary at all, because in a way there is when there is a middle provider, there is always some money that leaves that should be better spent into actually developing better outcome for patients. But it's exciting to see that we're all thinking about how to best make the transition, and there is no one way to do it. Many companies are finding different opportunities to facilitate it, and I think we need them all right now, because this is quite desperate, frankly.
We choose for a different kind of reimbursement above a new way of financing. Financing of a project is no problem. You can get the money from investors or for your insurance company, but if the pilot stops, the financing stops and the innovation stops. So we believe in our idea, so we made a new reimbursement program. So it's on daily basis you get you reimbursed, and you're financing your own innovation by new reimbursement. Yeah.
Thank you. It's almost getting out of time. It's a lively discussion, but maybe have a look if there are any questions from the audience. I don't see any hands, but maybe end with a tip from everyone. The audience will probably be many startups, investors, providers. Do you have a tip for embarking on value-based reimbursements, Marta?
Well, information technology is the coolest thing. I'm electrical engineer, qualified nerd, so I love that. But frankly, if you want to innovate in the space, you really need to be creative with business model innovations. That's where we are seeing some of the most interesting businesses emerge. And so know the space and be creative when it comes to understanding how to follow the flow, the money in the system, and you'll come up with something interesting.
I want to really second that. I mean, ultimately, don't be too fixated on one way on how to make money, but actually look how you can do it, because time and money in healthcare, comes in different time frames. Sometimes you have out-of-pocket that goes really fast. Sometimes you have like long contracts that take 1.5 years to create. I think the main thing is just don't focus only on one and don't get disencouraged on the way. No?
Thank you.
I think and I hope that all the creativity with the startups in innovating in technology and processing, maybe there's also some extra creativity to help us find the new reimbursement. And we can think about new models, but maybe this audience and the new startups are more competent to help us to find new reimbursement ways. So that would be the tip. Not only innovate on technology, but also help us with the new business models.
And I'd like to add to that, don't give up. As you mentioned, it takes 5 years, multiple examples. It's a long run, but it's the way we need to go. It's the direction that's going to make healthcare accessible for the future. So thank you all for being on stage. Thank you for listening.
Yep.
Thank you.